Good morning, everything. Dear participants of the Global Cancer Movement, I would like to thank to OncoDaily, to organizers of this event, my director, Professor Alma Zhylkaidarova, and I would like to share Kazakhstan experience of colorectal cancer screening. Kazakhstan is not classified as high incidence country for colorectal cancer. According to Globocan WHO, in 2022, the age standardized incidence rate was 15.5 per 100,000 population, and mortality rate is relatively higher at 8.6 per 100,000 population. Screening programs have proven effective in reducing the burden of colorectal cancer and are endorsed by WHO and other professional organizations. Kazakhstan introduced colorectal cancer screening in 2011, and at that time, you can see that 2.5 new cases, 1,000 men and women were diagnosed annually, and 1,500 patients died. Kazakhstan vast territory, low population density, and some environmental and dietary features contribute to regional variations in colorectal cancer incidence. As seen in map, in the northern, eastern, central, and central regions, the incidence rate of colorectal cancer is higher and is from 27 to 41 cases per 100,000 people. In the southern region, the incidence is low and ranges from 14 to 6 per 100,000 people. This slide compares mortality rate with the incidence rates, which are influenced by factors such as diagnostic quality, timeliness, and effectiveness of treatment. In some regions with low morbidity, relatively high mortality is noted. For example, the Jambu region, it's here. And vice versa, the regions with high morbidity, the mortality rate is almost the same as the national average. This is Karaganda, higher incidence and the overall mortality rate. We conditionally divided the implementation of screening program in three stages. The first is implementation stage. During this time, the regulatory framework, training of specialists, and information campaign among the population were prepared. What is screening? What are the benefits of screening? What are requirements for screening? The second stage is quality improvement stage. We introduced a fecal immunochemical test followed by total colonoscopy with the positive test results, prepared guidelines, developed a system of quality indicators and monitoring system. In 2016, Impact Mission, consisting of world-class experts, assessed the screening program and made recommendations for its improvement. The third stage is screening program optimization. During this period, we increased coverage, expanded age groups, began to pay more attention to identifying the cancer, the norms with patients' health improvement, and introduced sedation during colonoscopy. In 2016, the colorectal cancer screening program, along with other screenings, were accessed by WHO and IAE experts. Concerning colorectal screening, recommendations were given to strengthen monitoring of precancerous process and increase screening coverage. These recommendations were subsequently implemented. This slide presents the screening algorithm. Regardless of where the screening is carried out, in city, towns, or in countryside, all patients insured in the compulsory medical insurance system, aged from 50 to 70 years, who are not registered for cancer or colon polyposis, can participate in the screening. They are given a test which they perform at home or bring biological material to the clinic. In cases where blood is detected in the stool, fecal positive test, the patient is offered to undergo colonoscopy. Colonoscopy is carried out in diagnostic centers, in endoscopy departments at city hospitals or regional oncological centers. All morphological studies are carried out in laboratory of the regional oncology center. Based on the results of the colonoscopy, the patient is consulted by an oncologist, surgeon, or gastroenterologist. All screening results are entered into information system, and the interval of screening is 2 years. We utilize a qualitative chemical test capable of detecting hemoglobin level 50 nanograms and above. In many regions, a test made in Kazakhstan is used. In process of introduction screening, we encountered certain problems and continue to experience difficulties to this day. These problems affect the quality of the screening indicators, and accordingly, we are trying to solve them. Problems are of various nature. For example, low level of positive fit is noted. In this, quality of collection and interpretation of the material, or poor quality of the test. Low level of detection of adenoma detection. In this, the quality of the equipment, low level of skills of endoscopists, problems with morphologists. Of course, it is important to increase public awareness, to increase the level of participation in screening, and especially in colonoscopy. In some clinics, the participation rate of colonoscopy is even lower than 40% of the number of positive tests. For the quality of screening, regular updating of endoscopic equipment and training of specialists is certainly important. It is important to improve medical information system to obtain comprehensive and adequate information on all stages of screening for monitoring and quality assessment. At the start of screening, we prepare guidelines and list of quality indicators, including such as indicators as level of incorrectly conducted occult blood tests, the time between issuing a fit and obtaining a result, level of referral to colonoscopy, level of complete colonoscopy procedures, and time between the positive result of colonoscopy and the main treatment. Time is not more than 60 days. A standardized form for colonoscopy had been developed and implemented, which takes into account scope of examination, degree of intestinal cleanliness, according to Boston classification, biopsy results and complications, and procedure descriptions. Endoscopists undergo regular training program led by leading national and international experts. This slide summarizes the key outcomes of colorectal cancer screening in Kazakhstan over 13 years of implementation. Annually, more than 1 million people participate in our screening. Over the years, coverage of these eligible population increased from the 50% to 65 and 70% of target population. The adenoma detection rate varied between 17 and 25%. The cancer detection rate has consistently increased, currently at 0.04 of those screened. Early stage cancer detection improved from 7% to 41%, while advanced stage detections have significantly decreased over time. The proportion of localized cancer has remained relatively, you can see in this table, the proportion of localized cancer it has remained relatively stable on 54, 65, 66%. This diagram illustrates the distribution of cancer stage detected during screening, highlighting the growing share of early stage cancer and the decline in the late stage cases. Of course, the level of cancer detection during screening depends on the level of the basic morbidity and in a region with high incidence, we can see the cancer detection rate is higher in comparison with the country rate. And in the regions with low incidence, the level of cancer detection is also low. This Kazakhstan, Turkestan, Almaty Oblast. Of course, colorectal cancer screening is affected on the overall epidemiological situation, and you can see the over the past 20 years, there has been increased, incidence has been increased, and especially noticeable since the introduction of screening from 2011. During the COVID pandemic, there is a drop of the incidence, and now we can see the increasing of incidence. After the introduction of screening, there has been a tendency to decrease mortality. If the mortality rate at the introduction of screening was 9.5 per 100,000 population, in 2030, in last year, it will 7.0 per 100,000 population, and decline rate of almost 26%. The peak incidence of colorectal cancer has shifted to the age 60-70 years. Previously, before the introduction of screening, the peak incidence was at the age of 74. Currently, 4,000 new cases of colorectal cancer are diagnosed annually in Kazakhstan, compared to 2,500 13 years ago, and 1,400 deaths, more than 1,500 cases were noted 13 years ago. Our future plans include the implementation of the automatic quantitative hematography to improve the diagnostic accuracy, and we have experience of the pilot implementation of automated quantitative feed on 6,000 patients, and simultaneously with qualitative fit. And the main of the study noted the following advantages of quantitative hemocool test. Diagnostic value of automated fit was more higher than quantitative fit. Colorectal cancer detection rate increased from 0.03% to 0.15% for the fit test and 0.19% for the automated fit test, almost six-fold improvement. The detection of precancerous conditions rose from 0.09 to 0.47. And fully automated system minimizes errors due to human factors. In addition to the introduction of the automated quantitative hemocool tests, we plan to expand the implementation of virtual colonoscopy, especially among people who refuse classical colonoscopy or have concomitant disease that increase the risk of endoscopy. Starting in 2025, expert endoscopic centers based at regional oncological centers will operate in all regions of the country, and all screening colonoscopies will be performed in these centers. It is also planned to provide these centers with modern endoscopic equipment and appropriate training of personnel. It is also planned to increase coverage by including uninsured individuals. And these advancements aim to enhance the quality and accessibility of the colorectal cancer screening in Kazakhstan, improving early detection and patient outcomes. Thank you.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.